Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, I'm Eugene Wright, Medical Director for Performance Improvement at the South Piedmont Area Health Education Center here in Charlotte, North Carolina in the United States. Welcome to this discussion titled Protecting the Heart and Kidneys, Primary Care Strategies for Improving Cardio-Kidney-Metabolic Health. Joining me today is Dr. Janani Rangaswamy, Professor of Medicine at George Washington University in Washington, D.C., and the immediate past chair of the Council on Kidney and Cardiovascular Disease for the AHA. Today, we're going to take a look at the interplay between cardiovascular, kidney, and metabolic health, or CKM health, and what primary care professionals need to know. CKM is a common condition that is underrecognized and underdiagnosed. The global burden of cardio-kidney-metabolic syndrome is high and rising. However, CKM risk, if risk stratified, diagnosed, treated, and managed early using guideline-directed medical therapy, outcomes can be favorably improved. We have effective treatments and management strategies that, when used according to guideline-directed therapy, can significantly reduce the risk and slow the progression of the CKM syndrome. So let's just talk a little bit about the CKM syndrome. CKM stages range from 0 to stage 4. Stage 0 shows no cardiovascular risk factors, and the focus is on primordial prevention and preserving cardiovascular health. Stage 5, on the other extreme, shows significant clinical cardiovascular disease and a CKM syndrome associated with coronary heart disease, heart failure, atrial fibrillation, stroke, and peripheral artery disease. The stages in between show the pathophysiologic progression of this syndrome. This is a quick-fire exchange, and we'll have just 90 seconds to answer each question. So let's get started. Dr. Rangaswamy, what are the multisystemic consequences of poor cardiovascular kidney metabolic health?
Dr. Wright, thanks for that great question. It's a pleasure to be here. The most important aspect of CKM syndrome is that it's a multi-system disorder, and there is the interconnectedness between metabolic factors, such as obesity and diabetes, kidney disease, and poor cardiovascular health, with these factors being in the causal pathway to the genesis of cardiovascular disease across all phenotypes, but especially for ASCVD and heart failure. Like you really nicely outlined, the consequences are grim and they include premature death, cardiovascular risk, kidney risk, and also poor quality of life. And CKM syndrome drives healthcare costs in a truly unsustainable fashion for our health systems. CKM syndrome outcomes are further compounded in the context of adverse social drivers of health. So there are the biological risk factors, and then there are the socio-ecological factors that also contribute to poor outcomes, and they both contribute to this whole myriad of adverse outcomes we see in individuals living with CKM syndrome.
That was less than 90 seconds. What are the risk factors for CKM syndrome that primary care professionals should be aware of?
I think one of the factors that has really been spotlighted in the CKM syndrome construct is the upstream role of excess and or dysfunctional adiposity to most of the risk factors and the pathogenesis of that excess cardiovascular disease burden that is very unique, and it represents the interconnectedness between these factors in CKM syndrome. When untreated, many individuals progress from stage 1 CKM syndrome beyond that excess or dysfunctional or visceral adiposity to developing the more traditional risk factors such as hypertension, metabolic syndrome, diabetes, and eventually same risk factors also create incident chronic kidney disease. Untreated, these risk factors silently cause first subclinical damage in the form of subclinical cardiovascular disease, whether it be for ASCVD or for heart failure, the inevitable progression of CKD from lower risk to higher risk, and all these factors combine and ultimately drive that excess risk of CVD events and cardiovascular death. We should also not forget the very important amplifying role of metabolic liver disease that frequently coexists even at the level of stage 1 with obesity and further adds fuel to several of these mechanistic pathways that connect these risk factors to form CKM syndrome and its related risks.
Great. Let's go on to the screening and staging in primary care. Let's talk about the assessment of CKM risk factors in clinical practice. What should primary care professionals be doing and when? You have 120 seconds for this one.
Thanks, Dr. Wright. The great thing about showing that progression of risk in CKM syndrome is bulk of CKM syndrome lives in stages 1 and 2. And the true gatekeeper for these individuals in terms of their health care is their primary care clinician. So it is obvious that a lot of the initial screening and risk mitigation is in the wheelhouse of primary care. Starting from metabolic factors, annual BMI is something that primary clinicians are well aware of and have incorporated well into practice. Adding waist circumference to measure visceral adiposity, which sometimes is an even more powerful driver of adverse CKM outcomes than BMI itself. And we're really understanding a lot of the impact, especially for conditions like heart failure, is so important. What about kidney function? At least annual assessment of kidney function using two measures, not one: EGFR, which again, primary care clinicians do really well, but more importantly, UACR or urine albumin to creatinine ratio. Both matter in prognosticating not just the severity of kidney disease, but also are powerful predictors of cardiovascular risk and cardiovascular disease. Screening should be at least annually done. Keyword at least in those with risk factors for CKD, such as hypertension, diabetes, or metabolic syndrome. In those with established CKD, depending on the severity, more frequent screening will be important and necessary to capture additional residual risk. And then, how does a primary care clinician identify individuals with all these overlapping conditions who are at high risk for cardiovascular disease? There is a new tool as part of the whole CKM project that was released from American Heart, which is called the Prevent CVD Risk Calculator. And what it does is it captures the risk for total cardiovascular disease, which is both ASCVD as well as heart failure. Importantly, it also incorporates measures of kidney function in the model, implying that it is very important to screen for kidney function and kidney disease to be able to predict that cardiovascular risk. And any individual who scores greater than 20% for that CVD score at 10 years is somebody that the primary care clinician should be thoughtful about in terms of having and engaging them in conversations to intensify not only risk factor control, but also guideline directed medical therapies that can save kidneys, hearts, and lives. Those are the individuals that benefit the most. And when you consider the kidney piece alone, KDIGO has a really nice risk heat map In primary care, a lot of these individuals may have lower levels of risk for kidney disease and cardiovascular disease based on their GFR and UACR. And many of these can be managed entirely in the primary care domain. But in those who are, deemed to be high or very high KDIGO risk, not only do you want to get that initial treatment started in primary care, but you also want to refer to a nephrologist.
That's great. So now, does staging of the CKM syndrome help in decision making?
Absolutely. I think staging is a great opportunity in the primary care setting to allow engagement with patients. And it is never too late to have a conversation about prevention. And that's the beauty of the staging system. It just captures the totality of risk. And at anywhere you meet that individual in your practice, you can have that prevention conversation to show that we can prevent these adverse outcomes. Another nice thing about the staging system is it's a great way to inform patients that all these different diagnoses, diabetes and hypertension and obesity and heart failure, are not four different conditions. They're interconnected. They're all facets of the same problem. They share common mechanistic pathways. And the great news, therapies also have multi organ benefits. And I think that is so reassuring for patients to hear, to know that they didn't just go to a doctor and show up with 10 new diagnoses and different conditions. I think that's great for patient engagement and empowerment. And finally, by personalizing their risk using scores that are tested and validated in contemporary populations such as Prevent, it's now part of the guidelines for blood pressure therapy, for initiation of therapies, and the lipid guidelines that just came out. And just identifying that high risk individual, especially younger people, very motivating to show them that number to say, hey, listen, this is your lifetime risk. Here's what we can do. And it also allows us to take beyond that individual level, a population level approach to deploy preventive care, screening, and therapies.
That's great. You know, you mentioned that these were interconnected. Some would argue that they are interdependent as well. So, what role does social determinants of health, or SDOH, screening play in this?
That's a great question, Dr. Wright. Yes, they're absolutely interdependent, and these factors never come in isolation. They occur in tandem. And if you find one CKM risk factor, you're very likely to find others. If you look, it's only a question of looking and finding those, right? And you know this from your experience as a primary care clinician. Um, that's a great point about social drivers of adverse social drivers of health. Like I said, we talk a lot about during visits about mechanisms and shared pathways and shared risk factors, organ damage, whether it be heart or kidney. But the fact that usually gets left behind is patients don't just come to us with a cluster of biological risk factors. Starting from the society that we live in to the communities that we live in within the families and the system at the level of where people grow, where people go to school, where they work, and where children play. Every single factor matters and contributes to their health in so many ways. And I think one of the nice things about the CKM initiative and this whole concept is that as a framework, it recognizes that alongside biological risk, these socio-ecological factors deeply matter. The CKM Presidential Advisory advises on the strategies for systematic screening. There are validated screening tools to do this, to incorporate these into not just primary care, but also in CKM clinics and coordinated share care models, so that we are cognizant of where the problems are and can start addressing them. So I think it's so important. Every patient, every single encounter, adverse social drivers determine CKM outcomes. So, moving on, let's now talk about protecting the heart and the kidneys in clinical practice. Dr. Wright, can you share your thoughts on which therapies favorably affect cardiovascular, kidney, and metabolic health?
Yes, I like to think of these as the core pharmacologic pillars, if you will. And there's a very nice graphic that demonstrates that RAS inhibition using ACE inhibitors or ARBs, SGLT2s, nonsteroidal MRAs, and the GLP-1s can favorably impact the CKM progression. I like to think of these as providing layers of protection for the heart and the kidneys, but it's noted that this is on a foundation of holistic, approach to include lifestyle modifications, increased physical activity, reduced dietary sodium intake, smoking cessation, and weight management.
Those are so important, and I really like your term holistic care. All these factors, lifestyle and the pillars of therapy that you outline, they don't exist in silos. They truly have to come together, and that's the approach that you alluded to. So, building on that previous question, there are all these different classes of therapies. They all have high level of scientific evidence. Which therapies should primary care clinicians be using, when, and in what combinations?
Another great question. I like to think that when we use therapies, we want to slow the progression of this CKM syndrome. There was a great study that was done. It was called the Confidence Study. And the investigators wanted to examine whether the therapy with finerenone, a nonsteroidal mineralocorticoid receptor antagonist, and empagliflozin, an SGLT2 inhibitor, is superior to either agent alone in reducing urinary albumin creatinine ratio. Now, in this case, the albuminuria was being used as a mediating biomarker. Notably, the majority of these patients, 98%, were on an ACE or an ARB. And that's important to know because that's foundational therapy as well when you think about pharmacologic therapy. But also note that about 23% of patients were on a GLP-1. Now, it was shown that among persons with CKD and type 2 diabetes, with initial therapy, with the combination of finerenone plus empagliflozin, you had a greater reduction in the UACR than either treatment alone. If you look at the risk profile in terms of hyperkalemia and the sustained drop of greater than 30% in EGFR, again, the combination had a very favorable outcome and impact.
So, what are some practical considerations and tips and tricks you have for primary care clinicians to guide implementing these therapies in their clinic settings?
Another great question. There was a paper that was recently published on looking at a clinical care pathway for the pharmacologic management of chronic kidney disease in people living with type 2 diabetes. In essence, what we tried to show that following the lifestyle recommendations, which is foundational therapy, and the treatment of comorbid conditions, because these conditions are both interconnected and interdependent, an ACE or an ARB therapy, again, first line for blood pressure control as well as for kidney protection. Looking at the patient's EGFR for starting in SGLT2 with an EGFR greater than 20 mils per minute per 1.73 meters square, and adding in a nonsteroidal mineralocorticoid receptor antagonist, specifically finerenone, if the EGFR starting is greater than 25. The GLP-1 should be used whenever needed, irrespective of the A1C. As you've noted earlier, dysfunctional adiposity is a significant risk factor as well, and GLP-1s have been shown to have significant benefit in that regard, in addition to their benefit on kidney disease. Now, monitoring of these, you want to be able to monitor the patients if you're starting nonsteroidal mineralocorticoid receptor antagonists at about 4 weeks, and then periodically throughout the course of treatment, looking for changes in the potassium and the EGFR.
Those were some really nice clinical pearls, Dr. Wright. Thank you so much. We've had such an enriching conversation between the two of us, and I'm just going to summarize some of the highlights of what we talked about. First of all, cardiovascular kidney metabolic syndrome represents the interconnectedness between metabolic factors, kidney disease, and poor cardiovascular health. It has a significant impact on both the health span and the lifespan of individuals, not even talking about the excess economic burdens, largely preventable, treatable condition. A lot of the care for individuals living with CKM syndrome does begin and live in primary care because many of these individuals are very well within the range of either having just excess or dysfunctional adiposity or some additional risk factors where there is an opportunity for prevention at every visit to discuss CKM risk and how to personalize individual risk, not just based on these different conditions, but even by using newer calculators such as the AHA's Prevent CVD calculator. As Dr. Wright really nicely pointed out, there are several foundational pillars of therapies. We can go beyond one choice. We are really flooded with these options, and there are thoughtful ways, as nicely pointed out with their clinical guidance, on how to personalize and engage with individuals on their level of risk and matching the intensity of guideline directed therapies to that risk. Everybody doesn't need everything, but the high risk individuals benefit from combination therapies. We also saw some really nice data on the safety of using combination therapies. And I really think this is a game changer for how we can holistically approach CKM care and guide primary care clinicians and empower them to use these therapies in a confident and holistic fashion. Dr. Wright, thank you so much for being part of this really great discussion today. I learned a lot, and I know that our audience probably also got a lot of information out of these important clinical pearls. To the audience, thank you for participating in this activity. I hope you found it enjoyable and useful. Please continue on to answer the questions that follow and complete the evaluation. Thank you.